So thanks a lot for Dr. Martin Zaiac to give us this opportunity to listen to his lecture on nail and sign of systemic disease. He is a very well-known and leading dermatologist in South Florida, and he is a consultant in the area most prestigious hospitals and instructors at South Florida's top medical schools and universities, and an expert in new technologies and treatments for cosmetic and medical dermatological conditions. He's also a renowned expert on skin cancer as well as Mohs surgery, facial peels, laser treatments, Botox, and a lot of other things. His extensive experience has earned him an international reputation for excellence, and he's a frequent presenter at medical seminars and conferences around the world. We are really happy and grateful that you are coming back to this program, and we are looking forward to your lecture and learn from your experience. Thank you so much.
All right, so we'll get started, and I would trade all those nice comments that Laszlo told me if I could only kiteboard. So, anyways, maybe that'll be my next venture, to try the kiteboarding.
Okay.
Anyway, so tonight we're going to talk a little about nails as a sign of systemic disease. For the most part, there's some things that will be right on line with this, and then I have some pictures of some other uncommon or commonly uncommon nail conditions that are not necessarily related directly to systemic disease, but they can be seen. So we're going to go ahead and start. And I'm trying to get this. It's not advanced. Oh, I need to come over here. Okay, let me see. Okay, so the nail plate. Okay, the nail plate. Let me see. I have to get this other thing out of the way. All right. The nail plate and the nail unit, which have abnormalities, may be helpful as diagnostic tools in order to confirm some systemic disease. They can either be a clue or they can be diagnostic, okay? So you have to keep that in mind. There are specific and non-specific signs that we see. One or more than one nail can be involved. One or more than one nail can be involved, okay? If they can occur prior to this systemic disease, they can occur simultaneously to the systemic disease, or they can be secondary to any condition that we may be talking about. Most of the time, the changes are clues and they're non-specific. They're just reaction patterns that occur because of changes that occur in the matrix or the nail bed because of these systemic conditions. However, they can be diagnostic, meaning that when you see a particular sign, you know that that represents a specific disease. When evaluating the nails, you have to examine all the nails, the toenails, the fingernails, and obviously for women and some men, you have to have all the nail polish off, otherwise you really can't evaluate the nails accurately. Not only do you want to examine the nail plates, for nail plate changes, and if you have nail plate changes, the only way that they can develop is if someone traumatically does it from the outside, or if it's a matrix condition. Because as you know, the matrix is totally responsible for the nail plate development. The nail bed is a functional unit that helps push the nail plate forward and may contribute slightly to the ventral surface, but really the matrix is where the nail plate develops. So any changes that you see in the nail plate are caused from a problem in the matrix. Not only do you have to look at the nail plate and the nail bed, but you have to see the surrounding tissues, the periungual structures, the lateral and proximal nail folds, as well as the hyponychium and the glabrous skin around the entire unit, because that also may indicate things that are going on and can affect the nail plate and the nail bed. So nail changes occur from either one of two things or three things: outside job, which really doesn't count, or from a matrix involvement, which would then affect the nail plate, or from changes that are in the nail unit, meaning the nail bed, the lateral nail folds, or the proximal nail folds. You need to take a good history like with anything else. You want to measure the distance between the proximal nail fold and the changes that we see in the nail. And when I show you some pictures, you'll get an idea, because what's going to happen is if you see changes that are occurring, if you measure that from the proximal nail fold, let's say it happens to be 3 millimeters, you can pretty much approximately distinguish that whatever happened to cause that defect in the nail plate occurred 3 months ago, because we know that the nail average grows about 1 millimeter per month. And I'll show you a picture and you'll be able to get a better idea. All right? Also, the thickness of the nail plate will determine what's going on. It gives us an idea of how long the situation is going on. So this is a chart out of Bologna. And the first one, and we won't go through all of them, Bologna shows this chart, and the first one is Beau's lines. So you see a single independent line. Do you guys see the cursor at all or no? Like the arrow, do you see the arrow or no? Anyway, so
Yes,
this single independent line, the single independent line represents some event that took place in the matrix probably 1, 2, 3, 4, 5 months ago, or almost 6 months ago, that arrested partially the matrix and created this groove or defect in the nail plate. Typically, unless it's traumatic, you see Beau's lines in multiple nails because these are systemic things that are affecting all the nails and all the matrices and not just one individual nail. When you have complete arrest of the matrix where no matrix cells are producing any nail plate, you have what's called onychomadesis, which is complete separation. The old nail grows out and there's a split. It's no longer connected, and then a new nail, once the matrix starts producing, comes out again. So that's onychomadesis, and I'll show you an example of that. Onycholysis is super common and problematic because we really don't know exactly what caused it. It could be behavioral for patients that are like doing a lot of washing dishes, like dishwashers or bartenders, that their hands are in water, and this relationship between the nail plate and the nail bed gets disrupted and starts producing a space. So what happens when you get this space? Dirt gets in there, and what's the natural tendency for us to do is take something to clean it out. So you take a nail file or a nail cleaner and you start trying to scrape out that debris or that dirt. And what happens is, because that relationship between the nail plate and the nail bed is so sensitive, although you're cleaning out the dirt, you're actually microscopically separating it more and more and more. And it becomes a vicious cycle. So the best thing you can do for your patients, unless you can come up with a specific cause, which is difficult, is have your patients try to forget about it and only use a nail brush to clean. Because a brush is gentler and you can still get the same dirt out without having to be so traumatic or so, mechanical that's going to separate the nail more. Onychorectus we see quite regularly, and that's just a change that occurs with time. The nail plate develops these longitudinal defects or ridging. Onychoschizia is what we call brittle nails, where it starts to separate like in sheets rather than longitudinally. Trachonychia is associated with some conditions and just is more or less like onychorectus, but a little bit rougher. The oil drop phenomenon, or salmon patch, we see in psoriasis, and pitting, obviously we see irregular pitting, different sizes, different positions with psoriasis, but you also can see pitting in alopecia areata, and typically they're more uniform, all in lines, both horizontal and vertical, and mostly all the same size of the pits. So when you're looking at pits, look for irregularity in size and distribution, more favorable psoriasis, and more regular, look for alopecia areata. Diarrhea whites is a very unusual condition, but you see red and white bands, and you get these splinters, the V splinters or the V splitting. And when we talk about leukonychia, which is white lines, you have true leukonychia, where actually something's going on in the matrix that creates these lines, or you have what we call apparent leukonychia, where when you look at the nail plate, seeing through the nail plate, you see white colorations that are in bands, but when you press on the nail plate and you change the vasculature, they disappear. So the true leukonychias are something that's going on in the matrix that create damage to the nail plate, leaving true white lines. And apparent leukonychia is when you have apparent white lines that you see through the nail plate, but it's a vasculature change. And what causes that vascular change is that create these different types of patterns we'll talk about. But again, if you put pressure on the nail plate here and you blanch it out, these will go away and the true leukonychia will not. Another way to look at nails is in this cross section, which is very important for a lot of things, but I think most importantly for pigmented lesions or melanonychia, and I'll explain why. Obviously, this is what the normal nail would look like. Pincer nails, we know, are very sharp edges that go in and get caught up and cause a lot of pain. Yellow nails we'll show you lots of pictures of. Pachyonychia congenita is a congenital defect that you get thickening and subungual debris, and Koilonychia is spoon-shaped. But if you keep in mind, hopefully from this next picture here, that this is the nail unit. You have the proximal nail fold, which is normal skin. You have the hyponychium and the distal groove, which is normal skin. And then you have the nail unit, which is composed of the proximal nail fold, which produces the cuticle. The cuticle is like the stratum corneum of the skin that tends to shed off, but the cuticle attaches to the nail plate in such a manner that it forms a barrier and protects the proximal nail fold and then the nail unit from irritants such as detergents, soaps, waters, anything else. And when women and men push back that cuticle or cut that cuticle away, it allows for things to get in there, and that can cause irritation, that can cause inflammation, that causes paronychia. If they're chronically doing it and chronically putting their hands in water, you get chronic paronychia. If it's acute, you can sometimes get a secondary bacterial infection or a candida infection. It's very painful. So pushing back the cuticle is okay, but you don't want to take it completely off because it serves a purpose. The matrix are these cells here that are in the proximal part of the nail unit. And luckily for me and luckily for all of us, my uncle, Dr. Zaiac, described this whole nail unit and the function. So we know that the matrix cells that are back here in the proximal portion are responsible for producing the upper layers of the nail plate. So this cell, this first cell here, is going to end up being responsible for the top little layer of nail plate over here. And conversely, the ones that are distal, these cells here, are going to be conversely responsible for producing the cells that represent here. So going back to this cross-sectional picture, if you look at this cross-section, let's just say this was a melanonychia, and you saw a pigment that was on the top portion of the nail plate, you would know that it has to be a lesion that's producing the pigment in the proximal matrix. Conversely, if the lesion is in the middle of the nail plate, then it's somewhere in the middle of the matrix. And if it's at the bottom or the ventral portion of the nail plate, it's in the distal matrix. So once again, if your nevus or your melanoma is here, you're going to see the pigment on the upper portion of the nail plate. If it's in the middle of the matrix, you're going to see the nevus or the pigmentation in the middle, and if it's in the distal port, it's going to be on the bottom portion. I don't know if you guys can talk back, but hopefully you guys all understand that, okay? Because that's very important, because it helps you determine where you want to take your biopsy. You have to see here that unlike most of the skin, there's no subcutaneous tissue between the nail unit, some fibrotic tissue that adheres it, but right here is the bone. So there's really no space, and that's why when you get a trauma to your nail and you get a hematoma, it's so painful because there's nowhere for it to expand, and it basically just creates a pressure. So let's talk about some of the signs that you see. Subungual splinters, obviously they're longitudinal dark lines. They look like little wood splinters. Why do you get them longitudinally? Because they orient themselves longitudinally based on the anatomy of the nail bed. And if you know, I don't think there's a picture here, in cross-section, the nail bed looks kind of like the epidermis with dermal papillae and epidermal ridges that go up and down longitudinally along the entire nail bed. So it's like a channel. So a little drop of blood can find its way in that channel and create a long, splinter-like hemorrhage. If it's a really big hemorrhage or a big trauma, obviously it's going to, go away from the anatomy of the nail bed and become like just a pool of blood or a subungual hematoma. It can result from a small embolic event, whether it be from endocarditis or some of the collagen vascular diseases that cause little microscopic emboli, or sometimes larger, or it could be a capillary leak, or due to trauma. Obviously, the ones that are more distal are mostly secondary to trauma. Some of the pictures I'm going to show you that are more proximal are due to these other conditions. But when you see proximal and tender splinter hemorrhages, both proximal and tender, think subacute bacterial endocarditis or the collagen vascular disease, as well as the antiphospholipid syndrome, which also falls into that group. So here's a classic Splinter hemorrhages, you can see they're longitudinal, follow very narrow because it follows the groove of the dermal papillae that go up and down along the nail bed. Here it's starting posteriorly, or proximally, I should say. So here you want to think of an embolic phenomenon in someone that has endocarditis or maybe some collagen vascular disease. These grow out and eventually they fall off the nail plate and they disappear. But unless you have a recurring condition or recurring trauma, that's going to create those splinter hemorrhages. If you look at this with a dermatoscope, you can clearly see that it's hemorrhage or blood versus a pigmented lesion. Beau's lines, as we talked about briefly, are transverse grooves or furrows that are ascribed to temporary arrest of the nail matrix production. It's not the entire matrix, because if it's the entire matrix, then you're going to get separation. I was talking today to the students at FIU. As soon as that matrix cell produces the first layer of cells, that's the beginning of the nail plate. Those cells are basically dead and grow all the way out to be the extension of the nail. Just like I was comparing it today with a hair follicle. When that hair root or that inner root sheath produces that first layer of hair, that hair cell is dead. And it grows out because the other cells are underneath it are pushing it up. So the nail plate grows out because the matrix cells are pushing it forward. Okay, so if you have a temporary arrest of, let's say, 1/3 of the matrix, you're going to get the depth of the Beau's line is going to be 1/3 of the thickness of the nail plate. If you get the entire matrix involved, there's going to be no nail plate growing. So as that moves out, there's going to be a space. And then when the matrix starts growing again, you're going to get a new nail plate. So its total separation is onychomadesis. Beau's lines is when it's a partial groove or furrow. If it's a single lesion, I mentioned before, it's probably due to traumatic. Sometimes people have a tick and they can take a file and just kind of file it down. But when you see multiple nails, you have to think systemic. Most of these things are associated with some major illnesses, childbirth in women, chemotherapy, obviously, because chemotherapy is going to stop the production of matrix. And you can judge how long ago the event was, like we talked about, based on the distance the Beau's line is from the actual problem. So here is a relatively thick Beau's lines. It's not complete thickness, so it maybe takes up 2/3 of the nail plate, and it probably occurred anywhere from 5 to 6 months ago, because you think that this is about 6 millimeters or so from the proximal nail fold, and every month the nail grows a millimeter, a millimeter, a millimeter. So this is when this occurred. The patient may tell you, I had a really bad flu, and I had a very high fever, or I had some antibiotics, or I had a chemotherapy, or something that occurred systemically that's going to create that issue. On the difference is onychomadesis, where you see here the entire nail plate is separated. You see it's completely off, but you have a new nail growing underneath. And this is very, very common in children that have hand, foot, and mouth disease. It's the virus, for whatever reason, attacks the matrix cells, and depending on the duration of the virus, you can have a significant onychomadesis. And there was actually an epidemic that was described in Europe in multiple cities in the 90s, where by the hundreds, kids were coming in with loss of their nails, and it was related backwards that it was the hand, foot, and mouth virus that caused it. Koilonychia, or spoon-shaped nails, and I'll show you a picture, you see that the nail plate is thin and concave. In infancy, up to about 8 years old, it's physiologic and pretty normal. After that, you have to think about systemic disease. What's the most common things that we see? Iron deficiency anemia, associated with the Plummer-Vincent syndrome, and hemochromatosis. Here's an example of koilonychia in adults, and here's an example of physiologic koilonychia in a younger child. You can see it's like a spoon. If you fill this up with water, it would hold it, versus the normal nail, which is convex, and it tends to, the water would roll off the sides. So now we're going to go into the leukonychias, or what we call white nails, because leuco, from the white cells, white nails. So we talked about this a little bit, but you have apparent ones, which changes in the nail bed are seen through the nail plate, but they blanch with pressure. They're not permanent. The three most common that we see are Muehrke's lines, half and half nails, or Lindsay's nails, or Terry's nails. The true leukonychias, the changes occur in the nail plate, and they do not blanch. And the classic one of sign of those is what we call Mee's lines. So Muehrke's lines are typically double white transverse lines. They don't necessarily have to be in all the nails, but usually the middle ones, the second, third, and fourth digit. They represent an abnormality of the nail bed vasculature. Now, what causes that abnormality are various things, but again, they blanch with pressure. You see them, you push on the nail, and they go away. There are absolutely no nail plate changes. Why? Because it's not a matrix condition. It's a nail bed condition. So we see this most commonly in patients with chronic hypoalbuminemia, and if you can correct that defect, excuse me, or that deficiency, those white lines will go away. You can see it with nephrotic syndrome, you can see it with glomerulonephritis, you can see it with liver disease, malnutrition syndromes, whether it be anorexia or bulimia or pellagra, and chemotherapy. Here's an example of a patient with chemotherapy, and you can see here, there's a white band here, there's another white band here, and this white band is kind of falling apart. But also here, you have what we call onycholysis. So this was a patient with chemotherapy, developed onycholysis and Muehrke's lines. You can see that the lines represent that 1 month no chemotherapy, 1 month chemotherapy, 1 month no chemotherapy, 1 month chemotherapy. So it shows you those variations. Another example is the same. You can see the white bands over here on the thumbs with the onycholysis. Here are the white bands again. Muehrke's lines, clear white bands here and here with normal pink underneath it. If you press on the distal part of the nail plate, these white bands are going to disappear. They're apparent. They're not true. Half and half nails, or Lindsay's nails, are whitish in the proximal half, or they have that ground glass type appearance with a distal pink to reddish brown distal portion. It's a sharp demarcation. Again, it blanches with pressure. There are no nail plate changes because why? It's not a matrix disease. It's a nail bed disease. And we see this in patients that have chronic renal insufficiency, azotemia, uremia, and chemotherapy, particularly 5-fluorouracil. So here you can see that the proximal portion is white, or this ground glass, with a sharp distinction here, and then the distal pink to red to brownish discoloration. You can also see some other erythema in the skin, which obviously shows that this person is having some systemic issues. Another example, although it's not really halfway, but you can see this onycholysis that's separated. If it was attached like it's supposed to, that redness would go all over the end, and it would be almost half and half. Terry's nails are also a distinction of white discoloration to a reddish brown, but it's white all the way to the distal 1 to 2 millimeters of the nail plate. And then there's an exaggerated pink to brown band at the free edge. Again, it blanches with pressure. There's no nail plate changes because it's not a matrix disease. And this can be seen as a normal phenomenon with advanced age, or it can also be seen in younger patients, and you look out for cirrhosis, congestive heart failure, and diabetes. And here's an example of that ground glass white appearance from the proximal all the way to the distal 1 to 2 millimeters, where you have a sharp reddening of the nail bed. Really, it's the nail plate that you see the nail bed through, but this is the Terry's nails. So Mee's lines are totally different because now we're talking about something that does not blanch. Why? Because it's something that's occurring in the matrix that causes a matrix change that implants itself into the nail plate. Again, they're transverse lines and classically associated with arsenic intoxication. Multiple nails implies a systemic disease, and it does not blanch. So here's a typical Mee's lines, and this young chap in Great Britain was drinking coffee every 2 or 3 months with his wife and not knowing that his wife was poisoning him with arsenic, and laid down this leukonychia 2 months later again, and 2 months later again. And eventually, when they were doing the forensic studies, they found that it was arsenic poisoning, and he had these Mee's lines that were deposited from that. Clubbing is another phenomenon that we see in the nails, and usually it's associated with some type of cardiopulmonary disease. It can be idiopathic, it can be familial, and acquired if you have these diseases. You get these bulbous, fusiform, enlarged distal digits, and they feel spongy. I told you before, if you touch your nail now it feels pretty firm. There's no movement there because the nail unit is basically right on top of the bone. When there's clubbing, there's development of this edema type tissue, and it gets thickened and it gets spongy. You have an increase in both the longitudinal and the transverse curvature. It obliterates the normal Lavibon's angle and creates an angle that's normally 160 degrees, creates it to greater than 180 degrees, and you'll see that in a picture. This angle is measured from the dorsal surface of the distal phalanx and the nail plate. The acquired forms are usually related to systemic diseases. So in a normal situation, this would be 160 degrees, but when you have this clubbing and this stuff builds up, this angle becomes greater than 180 degrees, and that's the angle that you check to see if it's true clubbing or not. The most common causes of clubbing are associated cardiopulmonary diseases, 80% of them being respiratory and 10 to 15% being cardiovascular. So basically the cardiopulmonary or cardiovascular, the pulmonary or bronchopulmonary diseases, it could be neoplasms, infections, bronchiectasis, or primary fibrosis, sarcoidosis, and things like that. And the cardiovascular, GI, infections, a lot of different things have been associated, but by far the bronchopulmonary diseases are the most common cause for clubbing. Various examples of clubbing, you can see this exaggerated angle here, much better than 160 degrees, which is normal. There's a skin change associated. You can see this over curvature longitudinal. It almost looks like a beak-like, parrot beak-like nail. Not only is it longitudinal over curvature, but if you look at it horizontally, there's also almost like a pincer nail type deformity. Other examples here, you can see large. It can be associated with some onycholysis and onychoschizia. This is just showing the fusiform development of the distal digits with clubbing. If you correct the disease, the clubbing can get better. Yellow nails is another condition that is also caused from systemic conditions that reflect themselves in the nail. You get thickened, hard, and yellow nails, which you'll see pictures of. Again, there's an increased transverse curvature. The lunula are not visible because it's been replaced by this opacity, which typically is yellowish in coloration. The above changes are due to arrested nail growth. So when the nail doesn't keep shedding, the older nail gets opaque, it starts changing colors and turns yellow. It usually affects all nails when it's affected. It's rarely to see one or two nails. It usually affects at least 90% of the nails. True yellow nail condition is associated with lymphedema, respiratory tract disease, or as a paraneoplastic phenomenon. It can precede the disease or follow the disease, and if you correct the disease, it may resolve. So these are examples of yellow nails. These are hereditary, all 20 nails. But this is the typical yellow nails. It's thickened. You can see the lunula a little bit here, but it's harder to see. It's opaque. It's got that yellow thickened. You can see these little ridges are like tiny little Beau's lines that it's just growing oh so slowly or barely even growing at all. The patients will come in and say, I haven't had to trim my nails for at least a year. So you start looking, you ask them if they have any conditions, if they're having any problems, and hopefully you can figure something out that can help them. Another example, you can see they look rough, they look old, they're not growing. You see these little ridges as the microscopic amount of growth that occurs. Sometimes you get it trimmed back and you get this exposed nail bed, and this exposed nail bed will dry up and you'll never be able to get that nail plate to stick to the nail bed again. This is a patient I saw probably 3 or 4 years ago that was starting on Accutane, or isotretinoin, and started developing this yellow nail. And it was the earliest yellow nail syndrome that we've had. We stopped the Accutane, and it reversed back to normal. And here you can see another patient where the yellow nails are growing out, and the new nail is trying to come in from here to here, probably like 4 months or 3 months of new nail growth. And this is the old yellow nail. So if you reverse the condition, the nail can start growing back in its normal pattern. Next, we're going to look at things that cause proximal nail fold abnormalities. The most common thing that we see are dilated capillaries. Normally, and we'll show you a picture of normal capillary loops, they're very symmetrical, they're parallel, and they all have the same diameter. When things occur with various collagen vascular diseases, those parallel loops become less parallel, they change their dimension, they change their size, and they can become they can disappear based on the fact that some of them create ischemic phenomenon, and we'll talk about that in a second. In the proximal nail fold, you can also see splinter hemorrhages as a sign of collagen vascular diseases. You can get nail fold erythema as a sign of collagen vascular disease. And as it says here, these changes are associated with collagen vascular diseases. So in a normal person, you have lots of capillary loops. They're more or less the same size, and the distribution is even. When you have conditions that are in the lupus family, you still have a good number of the capillary loops. They still remain relatively parallel, but instead of being nice little loops, they call, like a board question would be corkscrew or tortuous. They become very tortuous, almost looking kind of like a corkscrew. With dermatomyositis and progressive systemic sclerosis, you get dilation of the capillary loops. They get much bigger, and then you get these ischemic phenomenon where these capillary loops end up, dying and creating scarring. So you have a paucity. You don't see that natural pattern here. You have 4 or 5, then you have a big space, then you have a couple more and a big space. So you lose the number, and they become very dilated. So for scleroderma or progressive systemic sclerosis, you have a paucity of visible capillaries. They get less because there's avascular areas because of these little tiny necrotic conditions. And when you do see them, they're usually enlarged, but still look like loops. In lupus, of all types, the density, like I said, is normal. You have the same number of capillaries, but they're tortuous, thickened, and they're corkscrew in shape. Dermatomyositis, you also get loss of these capillaries because of these ischemic phenomenon, but they're enlarged and maybe tortuous. Here's an example. I have to get a better picture, but you can see here that the loops are pretty much in order as far as the number. But you can see instead of being nice, simple loops, they're thickened and tortuous. And if you can really see it clearly, they have that corkscrew-like appearance. Here's an example of capillary loop pattern in progressive systemic sclerosis. You would see this in dermatomyositis. You have your capillary loops, but you have these areas where you lose them. Why? Because these little infarcts, these little hemorrhages that occur cause scarring, and these loops disappear. And then they become scarred down, and it creates other changes. So you have these little hemorrhages here, and you have these bigger, dilated, but paucity, less number of loops in these systemic sclerosis and dermatomyositis. Dermatomyositis also shows a very pronounced periungual erythema here. This occurs before you start getting these little infarcts, and then all of a sudden the capillary loops disappear. Why is it erythematous? Because, like I said, these vessels become much more dilated. There's more blood flow. It's going to get more red. And obviously, you know that you also look for Gauthron's papules, the heliotrope, and the Shaw sign. So here's a patient with dermatomyositis, lots of little proximal nail fold hemorrhages or splinter hemorrhages, a little bit of periungual erythema still, areas of large dilated vessels, but also areas where there's none. And they're associated usually with these embolic phenomena or little phenomena that cause these hemorrhages, and then these capillaries get scarred down and they start disappearing. Pterygium, we know, is when the proximal nail fold gets scarred down, typically from lichen planus, and the matrix disappears, and then the proximal nail fold grows right into the nail bed. In systemic sclerosis, there's a condition called pterygium inversum ungus, which means the pterygium, instead of being on top of the nail, from the proximal nail fold to the matrix, it's from the hyponychium down, and it adheres to the bottom of the nail. It's not very common. Again, it's the adherence of the distal portion of the nail unit or nail bed to the hyponychium, to the ventral surface of the nail plate. It's distal ischemia from these collagen vascular diseases that cause these microinfarcts that causes the scarring that leads to atrophy, ulcerations, and eventually the scarring which attaches to the nail plate or the pterygium formation. It can occur on 1 or 10 nails. The toenails are usually not as commonly affected. The symptoms, the patient will come in and you say, "Doc, I don't know what happened, but since about a couple months ago, every time I would clip my nails, it was extremely painful and sometimes would bleed." Why is that? That's because the skin that's growing from the hyponychium or the nail bed is attaching to the nail plate, and you don't see it unless you look underneath there, and if you clip it, obviously you're going to be cutting through the skin. So this can be either acquired as an idiopathic with scleroderma, formaldehyde induced from nail polishes, and peripheral nail damage like as in diabetics. Or Dr. Odom published an article about a familial congenital type of pterygium inversus. And this is what you see. This is a patient with scleroderma with some of these infarcts, some small calcifications, and you start developing this scarring to the point that eventually from here, where the hyponychium is on the nail, on the distal digit, all this tissue is scarred and it adheres to the plate. So if you can imagine, if you're cutting this nail here, you're going to cut the skin, it's going to be super painful, and it's going to bleed. So just some other things that we see with psoriasis. Obviously, you have what we call the racket nail deformity when you have the enthesis or the arthritis that creates inflammation around the matrix. It can either cause matrix changes like a nail pitting and crumbling of the nail, or it can cause nail bed changes, which are salmon patches and also nail bed hyperkeratosis. Here you can see extreme nail involvement of psoriasis with plaques of psoriasis on the surrounding skin. Here's a typical oil drop or salmon patch with everything else looks normal. This is acrodermatitis continuum of Halepo with psoriasis in the acral region with very heavy, painful psoriatic plaques, extensive psoriatic arthritis with extensive nail plate or nail unit changes. In alopecia areata, you have these regular pits that are regular in size and regular in shape, and that's associated with the alopecias. I don't understand. I just saw a picture that I had here of regular nail pits, but I guess I'll either try to find it or we all know what they look like. But the key is that in psoriasis, they're random, they're not regularly lined up, and they can be tiny to medium sized to big pits that look like if someone scooped out a chunk of the nail plate. Gout, which usually affects the joints, can also deposit in the distal digits and affect the nail unit by causing onycholysis here, or if it affects the nail matrix, it can cause changes in the nail plate formation. Proximal subungual onychomycosis is a marker for HIV. We're very familiar with distal subungual onychomycosis, where the fungus comes in through the palm or the sole, through the distal hyponychium, and makes its way in the nail bed and creates onycholysis with subungual debris. But proximal onychomycosis, you can see here, this distal nail plate is completely normal, but this whole area here is full of fungus. In an HIV patient or immune compromised, that can get underneath the proximal nail fold and give you proximal subungual onychomycosis. Acrokeratosis, paraneoplastica, Bazex are changes in malignancies of the upper respiratory tract or digestive tract that create specific nail, acral skin lesions, changes in the ears and on the nose. They're psoriasiform changes, but the lesions typically precede the malignancy. So if you start seeing these changes, which pictures is very, very rare, but if you see these changes where you have nails, ears, and nose, and it's very symmetrical, look for a malignancy. And the lesions can get better after malignancy is treated. So here you can see extensive psoriasiform changes, nail unit destruction basically. He's got changes on his nose, changes on his ear, and this is a patient that had a neoplastic condition. When they treated the neoplasm, this was before, and this is after. You can see it's starting to improve and looking much better. Obviously, these are classic pictures from Dr. Zaiac. It's a patient of mine with cutaneous T-cell lymphoma or mycosis fungoides. We have thickening, total involvement of the entire nail unit. The proximal nail fold is lost. There's thickened nail bed and thickened nail matrix cells that are producing this abnormal nail plates. So we're going to try to now group some nail conditions based on the organ system that it may be related to. The first group is cardiac and circulatory disorders. Clubbing, we talked about, can be seen, but by far pulmonary changes are the most important thing for clubbing. If you see petechia, subungual splinter hemorrhages, Osler's node, or Janeway's lesions, you have to look for bacterial endocarditis. If you see red lunula, instead of it being white, you can think of congestive heart failure. And Terry's nails we talked about, which are the ones that are approximately white until the distal 1 to 2 millimeters, also think about congestive heart failure. This is a patient I saw when I was a resident with a consult But bacterial endocarditis, these distal infarcts, the ones that got into the nail bed and nail matrix, cause these perturbed lesions and eventually, cause separation of the nail plate. This is a patient also I saw in a consult that had cholesterol emboli, secondary cardiac catheterization, where little chunks of cholesterol deposits got distal, blocked these vessels, and created this, necrosis and loss basically of this toe. You can see the livedo pattern of all the smaller areas where there was blockage as well. So what are some of the conditions that we see with respiratory disorders? We said for sure clubbing, could be lung cancers, pleural tumors, infections, bronchiectasis, or pulmonary fibrosis. You see the combination of clubbing, joint diffusion, periosteal, newborn formation associated with intrathoracic neoplasm. Think about this hypertrophic pulmonary osteoarthropathy. Very rare, but in the back of your mind, you may find somebody that has it, or it may be like a board question. And yellow nail syndrome, again, associated mostly with respiratory diseases, bronchiectasis, chronic sinusitis, bronchitis, and lymphedema. If you correct these things, you can get a little bit better improvement of your nails. What are some of the conditions we see with renal disorders? Mostly these apparent leukonychias, the Muehrke lines, which you can see with hypoalbuminemia and the nephrotic syndrome, and half-and-half nails, which is chronic renal disease and other things, uremic conditions, and azotemia. Hepatic disorders are things that are affecting the liver. You can see periungual erythema, like we saw with dermatomyositis, and you get these Terry's nails, which are associated mostly with liver and congestive heart failure. And also you can see them as a natural tendency with patients as adult onset. Going back and reviewing the connective tissue diseases, what we look for is the proximal capillary loop proximal nail fold capillary loop changes. We talked about in dermatomyositis and in progressive systemic sclerosis. They become a little bit more dilated because of these small infarcts that are going on. The capillary loops disappear, and you're left with these ischemic, atrophic, scarred down areas. You can see little bits of hemorrhages. In lupus erythematosus, the quality of the capillary loop changes and they become corkscrew and tortuous, but the number and their parallel alignment doesn't really change that much. When you see periungual erythema, you think of dermatomyositis. When you see anything that's going to inflame these proximal nail fold capillary loops, think of these collagen vascular diseases. You see ischemic lesions and ulcers like we saw in those patients with the pterygium inversus, think of progressive systemic sclerosis. And if you see a patient that complains about when they clip their nails, they're very painful, also think about progressive systemic sclerosis. Another example of dermatomyositis with the very pronounced periungular erythema, SCLERODERMA with the calcifications, the sclerodactyly or tapering down of the digits, and the classic pterygium inversus unguis. Again, microhemorrhages, microischemia with calcifications leading to scarring, which causes the skin to attach and becomes a very painful, condition. Systemic drugs can also affect the way your nail grows. They can either lay down pigment in the nail matrix or cause stimulation of the melanocytes to produce pigmentation in the nail. You can have photoonycholysis, which has always been associated with tetracyclines. Obviously, the psoralins we know are very photostimulated, so these can cause photoonycholysis. Pyogenic granulomas can happen naturally. They can happen due to pregnancy. They can happen due to pulling of the cuticle or getting an ingrown nail, but very commonly they're associated as a side effect of Accutane or the retinoids. Melanonychia or pigmentation of the nail can be caused by these medications, minocycline, AZT, which was one of the medications used for early HIV. We saw a lot of pigmentation. And hemorrhagic onycholysis you see when you have patients that are on chemotherapy for a long time. So here's pigmentation in a skin of color. You can think it's just an ethnic, hyperproduction of pigment. Or in this particular case, you can see the pigment is horizontal as well as longitudinal. This was due to minocycline. Pyogenic granulomas are these beefy tumors that if you touch them, they bleed a lot. We know it's overproduction of granulation tissue. It can be due to pulling the nail, or it could be due to pregnancy, or commonly associated with retinoids as a board question. And here you have onycholysis, but you also have hemorrhagic onycholysis with a little pseudomonas and pus development underneath the nail due to the taxons and chemotherapy. This is my last slide. This is my thumb and my daughter, who's now going to leave next week to start her first year in college when she was born, to show you how beautiful life is, that from these little babies we develop into beautiful young women. So thank you very much. And if there's any questions, I'm happy to address them.
Well, thank you very much, Dr. Zaiac. It was extremely informative, and I think that especially for people who are, starting dermatology, this was absolutely a great lecture, learning about the nails, anatomy, and the most important condition. It was a tour de force for all that. Thank you so much for this.